There's been a lot of changes in terms of the importance that we place on education about chronic pain itself. So that has been widely implemented in various different conditions in terms of chronic back pain, more rare conditions like complex regional pain syndrome. Understanding that knowledge base is there has really been a shift within the field itself, because oftentimes we just think, tell them about the condition generally. But here we're going a deep dive into pain, neuroscience, and physiology so that people understand central sensitization. They understand the ramp up, the gain of the system increase. They understand all of these different aspects and can apply that to their situation and say, well, this might make sense why I hurt more today. My name is Tasha Stanton, and I work as an Associate Professor of Clinical Pain Neuroscience here at SAHMRI, as well as at the University of South Australia. So here at SAHMRI, I lead the Persistent Pain Research Group, and at UniSA, I'm the Co-Director of Impact in Health. I work in the area of persistent pain, so pain that lasts a while, and I study numerous different aspects of it. So I try to understand what contributes to people hurting and what makes pain not go away. So we work with various different technologies, things like virtual and mediated reality, but we also use different cognitive interventions, looking at how people understanding more about their condition can actually really help. At the moment, we're undertaking a large clinical trial in people who have painful knee osteoarthritis, and we're testing what the effect is of teaching them new information, a contemporary story of osteoarthritis, pairing that with an individualized exercise program, and testing to see what that does to their pain and activity levels. Because the challenge right now for osteoarthritis is that actually many of the things that we think we know aren't accurate. For example, things like exercise and activity is actually critical for cartilage health. And yet we often think of those things as, maybe I shouldn't be doing those because I have osteoarthritis. So our trial is really testing to see what happens when we give people a good information base, when they help to understand their condition, when they feel safe to move, and what happens in terms of their life and how well they go. We know that pain is much more complex than we initially thought. So for anyone's given experience of pain, there are numerous things that contribute to what you feel. So context is really important. So as an example, if we zap you on the skin with a laser, it hurts more if we merely shine a red light than if we shine a blue light. Why? You've learnt that red is hot and dangerous. And we see these different contributors all the time. So what you believe about your pain matters. What you think is wrong with your body part matters. If you think, I need to find the cause, that can matter, because you can be very worried and stressed and anxious about what might be going on, which is entirely reasonable. But what we see in chronic pain is that very many different things will contribute to that experience of pain, but it's the system itself that has changed. It's no longer just about translating messages about, I've injured a tissue. Suddenly everything is ramped up. We see neuroimmune changes, which mean that the gain of the system itself has changed. And so many of our different strategies are actually trying to explore the different aspects that contribute to those increases in gain in the system. Well, this is just fun. So we use various different technologies. We do use things like virtual reality. So one of the things that we've created is a bespoke virtual reality bike. So you pedal away, you've got goggles on, and you see the world go by as you're pedaling. But we mess with what you see. So we use the fact that you've learnt, how hard you have to work to go up a hill. Or if I'm pedaling this hard, this is how fast I expect to go. And we manipulate it. And what happens is it actually makes exercise feel easier to you, and it makes it feel like you're working less hard and it's more enjoyable. So we're using these kind of perceptual trickeries to try to make exercise and activity easier for people with pain. But what we're also doing is we're exploring what happens when we change the way people perceive their bodies themselves. So as an example, if I see myself as quite muscular, you're actually better able to do things like a lifting task. You update based on the available sensory information that you have. So we're trying to use these peculiarities of our system to our advantage and kind of hijack them for good. There's been a lot of changes in terms of the importance that we place on education about chronic pain itself. So that has been widely implemented in various different conditions in terms of chronic back pain, more rare conditions like complex regional pain syndrome. Understanding that that knowledge base is there has really been a shift within the field itself, because oftentimes we just think, tell them about the condition generally. But here we're going a deep dive into pain neuroscience and physiology so that people understand central sensitization. They understand the ramp up, the gain of the system increase. They understand all of these different aspects and can apply that to their situation and say, well, this might make sense why I hurt more today. The other thing that we're starting to see, and I think is really exciting, is we're starting to see that technology is getting to the place where it's less expensive and we can start to integrate it into physiotherapy clinics, for example. So as part of a clinical trial, we're working with physiotherapists to trial out things like our virtual reality bike within the clinical setting so that we can actually begin to roll things out and change things on a wider scale. The Brain Bus is an initiative that I created about 5 years ago now, and the idea behind this is experiential learning. So you take a literal bus, actually, and you go out to different rural, regional, remote areas, and you engage with the community. And you give them examples of, for example, how your brain can be tricked. So we do things like the rubber hand illusion, where you give people a rubber hand, you touch it in the right way, and it feels to them like it's their own. You might see a clip on YouTube where it gets attacked with a hammer and someone freaks out, and we don't attack with a hammer during this, but we give people lived experience examples of how your brain is constantly dynamically modeling your body, and that it actually can be tricked based on the information that can come in. And if it can be tricked with things like vision, which is such a reliable sense, think about the ways that it might be tricked in terms of when you have pain. Lots of things can be not quite reading things perfectly, and understanding that your system can update and change also means that there's hope. There's possibility that if we give the right inputs, we can induce dynamic change in your system. We call this bioplasticity. So, and the reason we try to go to these different areas is because we know that in rural and remote areas, there, first of all, is not as much good information present in terms of services available, but also then the clinicians that work in those areas, they're less likely and able to access continuing education. So you get a relative, dearth of good information about pain in those areas. So we try to kind of go out to those areas and push that information there.